to, are you able to see my first image?
Yes, sir, I am.
Great stuff. Okay, what I'm going to do, I'm going to give you the remote control. And so it's candidate 1. There you go. You should have remote control.
Yes, sir, I do.
Okay. Now, with Zoom, the remote control that you control is the same as the one that I control. So in order for me to get to the next case, I need to ask you to stop moving the mouse. Is that okay?
Yes, sir.
Okay, that's great. So is somebody going to keep time? Or is that me? Okay, I'll keep time. It's fine. So 20 minutes and then 10 minutes of feedback. So candidate 1.
Sorry, I can keep time.
Sorry?
I can keep time.
Oh, fine. If you let me know when 20 minutes is up, I can then give 10 minutes feedback to candidate 1, and then we can go on to the next candidate. Is that okay?
Yeah, that's completely fine.
Great. Okay. So candidate 1, if you go ahead and have a look at this and tell me what's going on. Abdo pain.
Yes, sir. So I'm provided with the abdominal radiograph of a skeletally mature patient showing a calcified head of the right femur, and the shaft of the femur appears to be displaced laterally. There is some calcification noted in the left upper abdominal quadrant. I
Can
can
you just
also,
point that out to us?
I'm
You
sorry,
may
sir.
need to click. You may need to click before you move your mouse. Just point that out to the audience.
So right here.
Yeah. Okay. Good.
Yeah. I can also see the H-shaped configuration of the vertebrae of the lumbar spine.
Okay. Good.
There's a tube noted along the right, visualized like right lower lung zone.
Okay.
Um, uh, there seems to be paravertebral soft tissue pacification bilaterally, which is seen to
No,
displace.
that's okay actually. So you've got H-shaped vertebrae. You've got a calcified lesion at left upper zone, left upper quadrant. We've got. I'll come back to the hip at the in the feedback, but essentially it's an operation to remove a total hip replacement, and this is a young patient with abdo pain.
Right. So this is most likely a case of sickle cell disease.
It is sickle cell disease, yeah. So why do you think they've had an operation on their right hip?
So most likely due to avascular necrosis of the right
Yeah,
hip.
yeah. And is there any evidence of avascular necrosis on the left side?
So there's subtle sclerosis along the femoral head on the left side also noted. So that
Okay,
might, yeah, so that might represent early avascular necrosis on the left side too.
okay. And tell me why you've got that dense calcified structure in the left upper quadrant.
So that is a calcified spleen or the splenectomy, which is
Okay,
associated with the sickle cell disease.
good. Okay, another patient with abdo pain.
Yeah. So this is the radiograph abdomen of a skeletally mature patient showing a large AFL viscous, predominantly in the left abdominal quadrant, and displacing the small bubble loops on the right side. The base of this hollow viscous seems to be in the left lower abdominal quadrant, and it it is devoid of the hospital markings. So,
Yeah.
considering my findings, this is likely a case of sigmoid volvulus. I'd communicate these findings to a referring physician, advise
Sorry,
urgent surgical.
just tell me again. Is that you said a sigmoid volvulus? Yeah.
Yeah, that's what I said.
Now, if it was a sigmoid volvulus, would you expect the large bowel proximal to it to be dilated?
Yes, I would, sir.
And can you see proximal small bowel dilatation? Proximal large bowel
No,
dilatation.
I can't, sir. I can't see the proximal large bowel dilation in this case.
Okay, so can you see my arrows?
Yes, sir, I can.
You can, yeah. Okay. So is this large or small bowel?
So this is a small bowel.
So what should lie in that position?
There should be cecum, which should lie in this position.
And so what's happened to the cecum?
So the cecum has valves. There's volvulus of the cecum, and it is displaced in the left upper abdominal quadrant.
So what's the diagnosis?
This is a diagnosis of cecal volvulus.
Excellent. Okay, good. I'm going to take over the mouse now, so just that's it. Good. Right. Okay, what I want you to do now is I want you to scroll through that CT. The one on the left is the chest, and the one on the right is the abdomen.
So I'll just take a moment to scroll through.
Yeah, you take your time.
So, sir, in my the initial observation, I could see both the native kidneys, which appear small in size, and there is a transplanted kidney, which is noted in the right iliac fossa. In the bones, I can see increased bone density with multiple lucent areas involving the ribs and the vertebrae and
The
the
bone density's not increased, but tell me about the lucent areas.
yeah. So there are multiple lucent areas involving the ribs bilaterally, the vertebral bodies, and the pelvic bones.
Good.
Yeah. So based
Tell me
on
about the
these,
native kidneys as well.
they're both small and shrunken.
Okay.
Yeah.
So put it all together.
So it is most likely a case of secondary hyperparathyroidism, secondary to renal osteodystrophy, with
Okay, good.
brown tumors in the bones.
Yeah. And what operation do you think the patient's had in the neck?
Just going wild. Just give me a second. So he has had a thyroidectomy.
Parathyroidectomy. Excellent.
Yeah.
Okay, that's fine. Let me show you another one. Okay, this patient had high blood pressure and GP referred the patient for a chest X-ray.
So this is radiograph chest of an adult patient showing a well-defined opacity in the left upper lung zone, which has clear,
Right upper, don't worry.
right upper lung zones, which has
Yeah.
well-defined borders laterally and ill-defined borders medially. This opacity is seen to be above the clavicles, suggesting negative cervicothoracic signs, most likely the mediastinum. The trachea is also mildly
So,
shifted.
can I just stop you there? I just missed it. Which part of the mediastinum do you think it is?
Posterior mediastinum.
Yeah, that's good. Carry on. You're
And
doing
it is,
well.
yeah, in the posterior mediastinum. So I cannot see any other opacity in the lung, no evidence of any consolidation. There's no
Okay.
pleural effusion either side. The rest of the soft tissues and bones appear normal. So
Yeah.
Yeah, so this is most likely a case of posterior mediastinal mass, and my differential would include a neurogenic tumor,
Yeah, good.
schwannoma.
How would you investigate it further?
I would do a CT chest with contrast to investigate it further.
Okay, have a look at that. Does that fit with the schwannoma?
Yes, sir, it does.
Yeah. Would you be concerned that the contents of the schwannoma are very low density?
Yeah, it can be a cystic schwannoma, sir.
Yeah,
Or
okay.
yeah, the other possible differentials here of cystic density lesion could be a neuroenteric cyst.
Okay, that's fine. Okay. I'll take over the arrows, please.
Yes.
Okay. Have a look at this one. Okay, this patient has been investigated for episodic dyspnea.
Are these scrollable images?
Yeah, they are, yeah.
So there's diffuse ground glass opacification of both lungs with relative sparing of the lung parenchyma, intervening sparing of the lung parenchyma. The vessels within the lucent areas of the lung appear to be normal in caliber, so it's most likely the brown grass haze, which is abnormal in this case. I would go down further a bit.
Do you think the blood vessels in the black areas of the lung are smaller than the blood vessels elsewhere?
So I just need to go down. It's scrolling very slowly.
Okay,
What
I'll tell you
yeah,
what,
what I
I'll
see is the vessels in the lucent areas appear to be narrower
yeah,
in caliber
okay.
than the vessels
So
in the
so tell me, I don't want the diagnosis. I just want you to tell me what the basic pathophysiology of this appearance is.
so it could be due to air trapping.
Yeah,
Yeah, so there are areas of air trapping causing luminal narrowing of the vessels in the lucent areas of the lungs.
okay.
And
How would you confirm the air trapping?
so expiratory films, the expiratory
Okay,
scan. Yeah.
okay. This isn't an expiratory scan, but when you turn the patient prone, you effectively get an expiratory like scan on the dependent portions because the weight of the patient makes everything expiratory. Yeah. It's not the greatest example, but when we did the expiratory views, all of these areas were accentuated. So the difference in density between the two were accentuated. What's the most likely diagnosis given those appearances?
So bronchiolitis obliterans could be one of the differentials.
Is
Hyper
that common?
No, it's not that common. Hypersensitivity pneumonitis could be one of the differentials
Yeah, do you think
in
that's
this.
the most likely?
Yeah.
It is, isn't it? Okay, have a look at this one.
So this is X-ray hand
Yeah,
showing a soft tissue swelling along the proximal interpharyngeal joint of the third finger. And I can also see some soft tissue swelling along the proximal interpharyngeal joint of the second finger. Uh, the the joint itself appears to be normal. I cannot appreciate um, erosions of the joint. There's some soft tissue
Just show me the joints that you're describing. Just use your arrow. Yeah.
So
Now,
the right here.
and you can't see erosions, or you can.
So there's some erosion here on this side and some erosion on that side.
Okay, and what do you call the position of that erosion?
Juxta articular.
Articular. And
Yeah.
what about the density of the soft tissue swelling?
Most likely a calcific density, because I can see some high density areas with it.
So what's the most likely diagnosis?
The gout.
Yeah, tophaceous gout. Well done. Okay. This patient is a young lady complaining of abdo pain.
This is radiograph abdomen of a young lady who's complaining of abdominal pain. I can see sclerotic foci along the right sacral ella.
Can you point that out using your mouse?
So right here.
Yeah. So just for the audience sake and your sake, the reason I'm asking for that is so that they can see it, but also the examiner might want to see it as well. Yeah. So what do you think it is?
So this could represent a dermoid, a right adnexal dermoid.
Okay. Can you see any other calcification anywhere?
Looking for it, I can't
These are
find
teeth.
it.
Yeah.
Yeah.
Can you see any calcification anywhere else?
There is no calcification anywhere else. I can't.
Just there, maybe. Can you see
Yeah.
that? Very faint. Yeah, this was a dermoid. Okay. This patient comes into hospital with complete heart block, and I want you to report this chest X-ray. How am I doing for time, Bhumika?
Sorry, we have about 4 minutes left.
4 minutes left. Okay, that's great.
Yeah, so this is
So go ahead, candidate one.
Sir, this is radiograph chest of in semi-erect position of an adult patient, showing multiple ECG leads, and there is a central venous catheter, the tip of which is noted in the right ventricle. So this, I guess, is a Swan-Ganz catheter.
No, it's not a Swan-Ganz catheter. That usually resides in the pulmonary artery. Now, the patient came in with a complete heart block. So what's the treatment for that?
The treatment for complete heart block would be ionotropics along with the defibrillation.
What about a pacemaker?
Yeah, but I can't see the pacemaker anywhere.
The pacemaker is the line that is in the right ventricle. So it's a temporary pacemaker.
Yes, just below the right hemidiaphragm.
Yeah. No. Let me take control.
Yes.
This line here is going in the internal jugular, SVC, cavo-atrial junction. Sorry, that's me. Right atrium and right ventricle, and it paces the right ventricle. Okay.
Right. So
now, the patient then, once they've had the pacemaker put in, that corrects the complete heart block, which is causing heart failure. So the patient now goes back into some sort of paced sinus rhythm, but they're also complaining of chest pain. Why?
Sir, I'm looking for pneumothorax. There is a slitting of the left hemidiaphragm.
Just point that out to me.
Right here, the right hemidiaphragm seems to have sharp contours. I
Yeah.
cannot appreciate the left hemidiaphragm medially. And
So I'm just going to help you for a second. Hang on a sec.
yes,
The left hemidiaphragm is seen. There's a bit of atelectasis, okay, and there's a bit of circular or semicircular calcification here, which probably indicates some calcification of the mitral valve annulus, okay? But can you see this lucency in the cardiophrenic sulcus
yes, sir, I can
and
see
the deep sulcus on the
the
right?
sign on the right side here.
What's the diagnosis?
The pneumothorax are on the right side.
Okay, good. Why is it seen more at the base than the apex?
So in supine position, it is seen more in the base than the apex.
Yeah, and the patient's semi-erect, which also means what?
More or less a supine position.
Semi-erect is semi-supine, same thing, isn't it? Okay. So have a look at this one
Right.
and tell me what you think. Little
So
old lady falls over and um, has a painful arm.
Sorry to interrupt. We've hit the 20-minute deadline.
Okay, well, you can finish this candidate one and then I'll go through the feedback, yeah?
so there's a defined mass in the left upper lung zone with a pathological fracture.
Is it left or right?
Right, because the marker is on the right side.
Yeah, so it's the right side. Okay, don't worry. So there's a mass lesion in the right upper lobe
Yeah.
and there's a pathological fracture through the distal humerus. Yeah, well done. Okay, how do you think you did?
I think I did okay.
I think you did really, really, really well. I'm going to go through each film in turn, and I'm going to go through for the benefit of the audience because I thought you did really well, but also just a bit of teaching around the films. So this is I'll take the controls if that's okay.
Yes, sir.
Okay, thanks. So don't touch the mouse. That's it. Great. So I can flip that horizontally. There you go. So it's right. There's the lesion. So pathological fracture. Whenever you see a pathological fracture, think if it's lucent, think breast, bronchus, thyroid, kidney. Also think about myeloma and also think about lymphoma. Okay. But this clearly is due to a bronchial carcinoma because you can see it on the same film. Now, there might be a chest X-ray where you've got pathological fracture and you've got a patient who's got maybe a mastectomy. So in other words, when you see this in the exam, look around the rest of the film and make sure that there's nothing else that could be a clue as to the primary malignancy. Okay, so that was good. In no particular order, that was a schwannoma of the thorax. So it's a posterior mediastinal mass. It's sharp above the clavicle, okay, which means it's not arising from the anterior mediastinum. Even though it's in the middle or posterior mediastinum, it's still large enough to cause tracheal shift. Always worth mentioning that in the exam, okay. And the important thing here is that you look for splaying of the ribs. Now, you could argue that there's a little bit of splaying of that rib compared to, say, the other side. Yeah, it's not much, but it's 0.2. So posterior lesions tend to splay the ribs as well. So it's always worth mentioning that. to the examiner if you can. I
Yes.
didn't show you this, but here is the T1 weighted image with gadolinium. And this is an area of enhancement. So although the lesion looks as if it might be a cyst, okay, the very fact that we've got some enhancement inside that cyst in inverted commas means it's cystic solid. Yeah. If it was a pure cyst, you wouldn't see that enhancement. And that turned out to be a schwannoma. Yeah. So that was good. You nailed that one very well. That is a cluster of teeth, and just above it, there's some more calcification just there. You can just see it there. Okay. And this is all part of the dermoid, and you would confirm that with an ultrasound. Tophaceous gout, so we've got juxta-articulate erosions, and the hallmark of gout is the fact that the soft tissue swelling around the joint is dense because the uric acid and calcium combine to form this dense tophaceous soft tissue density. You can see it here as well and here. Now, I thought you were going to come out with the right diagnosis immediately here, but you said sigmoid volvulus. Now, a sigmoid volvulus is completely different from a cecal volvulus, and I'm going to show you that. Just bear with me 1 second. Just going to do something. Sorry. I'm just going to show you a sigmoid volvulus on the same page, if that's possible. Just bear with me. Please don't move the mouse. Okay, sorry for the delay. So in a cecal volvulus, the problem is in the ascending colon mesentery. It twists on the mesentery, and the left, sorry, the cecum then moves into the left side over here. And then the space that's vacated by the cecum is filled with small bowel, which may or may not be gas filled, depending on whether it's fluid filled or gas filled. But a cecal volvulus, in effect, does give you small bowel obstruction because you can't get past the cecum because it's twisted. Yeah. But the important thing about a cecal volvulus is that everything that's distal to the cecum, in other words, the ascending colon, the transverse colon, the descending colon, collapses. Okay. And so there is no large bowel here, apart from the cecum, which is flipped over. Whereas a sigmoid volvulus, because the obstruction is so distal, you get the coffee bean that's coming out of the pelvis, and it overlaps a dilated descending colon, which you can see here. And the dilated descending colon is called the left flank overlap sign. And it tells you that it must be a sigmoid volvulus. So this is a sigmoid volvulus, this is a cecal volvulus. So the take-home message is distal to the cecum, the large bowel collapses. with sigmoid volvulus proximal to the sigmoid volvulus, the large bowel dilates. Okay.
Yes, sir.
And let me just go back to, we showed one more case, I think. Oh, two more cases. Okay. So let's go back. Okay, got H-shaped vertebrae. We've got autoinfarction of the spleen. We've got avascular necrosis of the left femoral head. This is a patient who's already had a total hip replacement. That's been removed, and there's been a cement ball impregnated with antibiotics as a primary procedure before they have a replacement, total hip replacement. But in other words, the patient's been subjected to an orthopedic operation because they've had AVN. And the other thing you didn't mention, minor point, but patient's got right pleural effusion, which you can just see here. And then this is a double lumen line, which presumably is for the administration of painkillers, antibiotics, etc. And the last one was this one. Yeah, so this is a classical case of extrinsic allergic alveolitis. And you get ground glass change. So initially what happens is you get little central-lobular dots, which represent airways granulometer. And then they get bigger and bigger and bigger and start coalescing to form this ground glass change. And then you've got areas of non-involvement, which are these secondary pulmonary lobular areas. And these are the areas of air trapping. And because you get air trapping, that leads to hypoxia. And the hypoxia leads to vasoconstriction. So the arteries that go to the lucent areas become very narrow, and the arteries that go to the grey areas remain the same size or get slightly bigger because of shunting. And the most likely diagnosis is hypersensitivity pneumonitis. So in the UK, it's things like pigeon fanciers lung, farmer's lung, anything organic really that can induce this. And one of the things that you need to ask for, which you rightly did, was an exploratory study. Great. So I thought that was really well done.
Thank you.
You would, if you adopt that technique in the exam, you'll smash it. That was really well done.
Thank you, sir.
Okay. So candidate 2, please.
Hello, Dr. Curtis.
So I'm going to remove your remote control, candidate 1, and I'm going to give it to candidate 2. Okay, and like before, if I ask you to stop the mouse, it's only because I need to get you the next film. Okay.
Sure.
And we'll be fighting over the mouse. This is slightly different with Teams, by the way, because with Teams, the examiner and the candidate independently can move the mouse without fighting. But with Zoom, we're going to fight over it, I'm afraid. So,
No problem.
okay, here we go. Right, so Bhumika, if you start the clock now, 20 minutes.
Yeah, sure, of course.
Okay, so I'm presented with a hand radiograph of an adult patient. On this radiograph, I can see the first thing that's striking to me is hook-like osteophytes.
Yeah.
of the third, fourth MTPs.
Point them out to me.
So I can see one on the third.
You need to click before you move your mouse.
Oh, sorry.
That's it. Okay, got it.
I can see degenerative changes also going along on the first MCP and sort of DIP joints.
Yeah.
And so some TFCC calcifications along here as well. So a top
Good.
differential for this, given these findings, would be hemochromatosis and CPPD. But given the distribution of the hook-like osteophytes, I would think about a hemochromatosis.
Good. Okay. Have a look at this next one.
Okay, so I'm presented with a focused a chest radiograph of a
Patient's wheezy.
wheezy. Okay, fine. So presented with a adult PA chest erect radiograph. On this radiograph, I can see bilateral upper zone triangular peripheral increased density pacifications. And I can't see anything else apart from that that's sort of jumping at me. So this is a case of a mid to upper zone peripheral consolidative changes. This could be keeping with peripheral eosinophilia or peripheral eosinophilic pneumonia as one of my differentials. Yep. I would refer my findings back to the clinical team and ask for patients of history and consider doing a CT chest with contrast.
Okay, that's fine. Okay, this patient is complaining of dysphagia. Okay,
so I'm presented with a chest radiograph of an adult patient. The most striking abnormality is a sort of linear density, which seems to be demarcating what looks to be a dilated esophagus. Just sort of pointing out with my mouse in this particular region is what I'm looking at. And I'm looking for any sort
of... why do you think it's a dilated esophagus?
Given the patient's got a history of dysphagia, I can see the linear lucency band, which is tracking all the way down towards the stomach region.
Just show me with your mouse.
So here, and I'm going all the way down, and I suspect it's the...
It could be an esophagus. Could it be anything else?
So the bronchus central, so I don't think it could be that.
Have a look at the sixth rib on the right.
6 rib, 1, 2,
3, 4. Look at the sixth posterior rib on the right.
Okay. So there's a sort of triangular sort of opacity.
Just show me.
So I'm looking at this particular region here.
Just show me where the posterior sixth rib is.
Okay, so if this is 1, 2, 3, 4, 5.
No, you're going far too fast. Stop. Go slowly. Show me where the first rib is.
This first rib is coming down here.
Where's the second rib?
Second is here.
Where's the third rib?
Third is here. Fourth is here.
No, hang on. Whoa. Go posteriorly. Where's the third rib posteriorly?
Third rib posteriorly. 1, 2, 3. So that should be... tracking down here.
No. I'm gonna do it for you. Just let me take control. There's the first rib. Agreed. Can you see that? Agreed?
Yes.
There's the third rib. There's the fourth rib. There's the fifth rib. And tell me about the sixth rib.
So looking at the sixth rib on the sort of lateral margin, it looks relatively, it's like a lytic.
It's not lytic. What else could it be?
So it's got to be sort of sclerotic. I can't see any rib notching. There's a soft tissue density actually overlying the.
Well, hang on a second. If that's not the esophagus, what else could it be?
So it could be somewhere in the posterior mediastinum.
Okay, don't worry. I'll go on to the next case. Okay, so this is a 25-year-old male who has been on ITU 4 times with respiratory failure. 25.
Okay. 25. So presented. Just going to scroll for my findings and then. It seems to be jumping.
Do you want me to scroll for you?
Yes, please.
I'll do that for you. Don't worry. Okay, so there's the top of the chest.
Okay, so on the right side, I could appreciate some lung collapse.
Yeah, good.
So now I'm just going to check for if there's any anything obstructing the endobronchial.
There isn't. Don't worry. In the interests of time, I'm going to help you. So there is a right lower lobe collapse.
Yeah.
And excuse me, and I think the middle lobe is also collapsed, isn't it?
That's right. Yeah.
Okay. There's a bit of consolidation in the left lower lobe, and there's also a bit of consolidation in the right upper lobe. Okay. Right. That's enough lung windows. I want you to concentrate on the abdominal windows now. So tell me what you think about those.
Okay, so I'm looking for. Okay, so switch screens. So looking at the abdomen, kidneys look okay.
What do you think is missing in this patient?
The right hemipelvis is not clearly visualized.
Patients are slightly tilted in the gantry. Where are the gluteal muscles?
Oh, they're absolutely they're absent. This is replaced with essentially.
Replaced with fat, yeah? Where are the pectoral muscles?
They're also
Where are the
absent.
scapular muscles?
So all the muscles, it's aplasia of essentially the muscles. I guess.
So what's the diagnosis?
Poland syndrome?
No. Does Poland syndrome affect the gluteal muscles?
No, it doesn't.
Okay.
Maybe some form of muscular dystrophy.
Yeah, which one?
Duchenne's muscular dystrophy.
Yeah. How is that inherited?
It's X-linked.
Is it recessive or dominant?
Dominant.
What's the opposite of dominant?
Recessive.
Excellent. Well done. Okay. Why do they get respiratory failure?
Sorry?
Why do they get respiratory failure?
Because of muscle weakness and can't breathe, intercostal muscles lacking, and muscle weakness. Actually.
That's fine. Okay, so Have a look at this next one.
Okay, so
Abdo pain.
abdo pain. Okay, fine. So presented with abdo-pelvis contrast enhanced study. I'm just going to scroll and then present my findings. So the area of interest seems to be in the lower abdomen. I can see pneumatosis
Yeah, good.
off the bowel. Just apologies, it's just jumping from slice to slice.
I'll scroll for you then. Is that okay?
Sorry,
Yeah, it might be the internet connection got possibly.
Okay, so I can appreciate an NG tube. I can see portal venous gas in the liver.
Good. Why is it portal venous gas and not biliary gas?
It's going all the way to the periphery.
Okay, good. And what else can you see?
Bit of bilateral pleural effusion. So now I'm just looking at vessels to check for sort of ischemic changes and find out the cause of the pneumatosis.
What's a good window to look at blood vessels? What window do you look at blood vessels with?
Probably window with about 60.
Okay, I look at it on bone windows because it's quite good for looking at calcification. And you can see that the superior mesenteric artery is heavily calcified. Yeah.
Yes,
And
the
so
whole aorta, predominantly.
half of it is calcified. So you only need a small amount of thrombus to give you ischemia. Yeah.
Yeah. So this is probably a case of arterial ischemic changes.
Yeah. Good. Okay.
Okay, so I'm presented with a frontal chest radiograph.
Yeah, I'll just give you the story. This lady is 65 and she's got weight loss and cough.
Okay, so presented with a frontal chest radiograph of an adult patient. I can see that there is a large, well-defined opacity overlying the right upper zone. And I can't, and it seems to be tracking from the hilar region as well at the same time, and I can't really see any other satellite-like lesions else.
What's the most likely diagnosis given that story?
Lung malignancy, lung cancer, adenocarcinoma of the lung will be my top differential.
So actually, it turned out to be a squamous carcinoma of the bronchus, and it was resected with a right upper lobectomy. Okay, and 2 weeks after the operation, patient returned with this X-ray. Okay. Oh, sorry, wrong one. Patient returned with this X-ray here on the left. Tell me what's wrong there.
So I can see that there is a sort of a lucent lung with no air markings. Lung markings.
So what do we call that?
That'll be. It feels like it's a pneumothorax going on.
Yes, yeah. So in somebody who's just recently had an operation, what would be the cause of the pneumothorax?
So somebody that has recent.
So they've had a right upper lobectomy, and now they've got pneumothorax. So what's happened?
Unless there's a bronchopleural.
Yeah, bronchopleural fistula. So effectively, what's happened is the bronchial stump is broken down, and it's now in communication with the pleura. Yeah. So you've got a bronchopleural fistula, and you've got a situation where you've got the pneumothorax. It's tethered to the side because, of course, during the operation, a all sorts of adhesions in the pleura. Yeah. Now, that was a bronchopleural fissure, and that was treated appropriately. Okay.
Yes.
Now, tell me, what's the difference in technique between that X-ray and that X-ray? They're both PA X-rays. So the radiographer who did this X-ray asked the patient to do something different to the radiographer who did this X-ray.
We ask the patient to take a deep breath in.
Oh, well, they both took a deep breath in. How many different ways can you do a PA chest X-ray?
I guess there's multiple ways. Is it in terms of how they?
You could ask the patient to put their hands on their hips or to wrap their arms around the cassette like that. Yeah.
This one looks as if it's by the hips, based upon what I can see on the image.
Okay. So, if a patient's got their hands on the hips, are you going to ignore them or are you going to look at them?
I would look around the film as well to see if there is.
Going to help
some?
you here. Hang on a second, just to save time. Okay, now.
So, is there some sort of periosteal reaction that I can see?
Yeah.
Yeah, it's a periosteal reaction, which is probably keeping with hypertrophic.
Show the audience the periosteal reaction.
So here I can see.
Just click and then move your mouse. That's it. Yeah. Is it anywhere else? Yeah.
Yeah.
Okay, so put it all together.
So this is a case of lung cancer, which is a lobectomy and secondary complications of a hypertrophic osteoarthropathy.
Can you see it on the original film?
On the original film, I can't really appreciate any. I can't even see the. Oh, on the clavicle, there is some periosteal reaction that can be appreciated on the mid to distal clavicle.
Okay, that's good. Okay. Okay, have a look at that chest X-ray. This patient is seeing their GP with a history of hypertension.
Okay, so I'm presented with a chest radiograph of an adult patient who's presented who has hypertension. What I can see is that there is a well-defined lesion in the left mid to lower zone, and I can appreciate some rib erosion of the posterior, I think, sixth rib. And looking at sort of, can't see any pleural effusion, and I can't see any other sort of bone lesion. So in summary, this is a case of a lung, top differential will be a lung malignancy with bone metastasis. I would compare with previous imaging, do a CT thorax for further evaluation with contrast and refer to lung MDT.
What do you think the most likely diagnosis is?
I was suspecting that it's going to be lung with bone metastasis.
Okay.
Other differentials to consider, can't see any brush shadows to suggest that this is a female patient.
What does the scalloping of the rib suggest?
Scalloping of the ribs could suggest it could be a other differentials going to be osteosarcoma could be one of the differentials to consider.
Okay, let's move on to a different case. Have a look at this one. 25-year-old male without any history of cardiac disease presents.
Sorry,
so
we've just hit the 20-minute mark.
Okay, go on. We'll carry on.
no problem. I presented with a upper chest X-ray of an adult patient. I can see bilateral pacification of both lung fields. I can't appreciate the left hemi diaphragm or the right to a certain extent. Given that this patient has no cardiac history, this could be in keeping with a non-cardiogenic pulmonary edema.
Do you know any causes?
Nothing coming to my mind at this moment.
Don't worry.
I guess COVID to a certain extent can potentially do it. Maybe drug.
So if it's non-cardiogenic, you need to think about things like fluid overload. Yeah. Or you could be smoking,
Drug
or
toxicity.
it could be neurogenic pulmonary edema. So head injury or subarachnoid hemorrhage. Yeah, something like that.
Yeah.
And this patient, what's the cause in this patient?
It's because of a bleed, subarachnoid bleed.
Yeah, so subarachnoid bleed. Patient then goes on to have
Chest X-ray.
pulmonary edema, non-cardiogenic or neurogenic pulmonary edema. And this subarachnoid hemorrhage is spontaneous, not trauma-related. We've got blood in the fourth ventricle, blood in the prepontine, ambient and quadrigeminal cisterns, blood in the Sylvian fissure, and then we've got a hematoma around the anterior cerebral artery. So most aneurysms occur at the junction of the anterior. Oh, voice is not clear. Is that my voice or the candidate's voice?
I can hear you clearly, Dr. Gates.
Yeah, okay, that's fine. Okay, so we've got a hematoma around the anterior communicating artery and anterior cerebral artery, and it's almost always at the junction of an artery and another artery. So the likelihood is that there's an aneurysmal bleed in that part of the circle of Willis. But the consequence is that the patient who's got no prior history of cardiac disease gets pulmonary edema. So the things to remember about non-cardiogenic pulmonary edema, things like drowning, smoke inhalation, drug reactions, like overdose of narcotics or just a hypersensitivity reaction to a drug. Then neurogenic causes, and they're the main ones really. And just a nice demonstration of non-cardiogenic pulmonary edema. Okay, so how do you think you did?
Could have done better, but okay.
No, that's okay. Now I'm going to show you the one where, if you get this in the exam, not only are you going to nail it, but you are going to send me a £1 John Lewis voucher. Yeah.
Sure.
I'm only joking. Don't do that. Don't do that. Okay. So this looks like an esophagus, but it's rather thick-walled, isn't it? Almost with its stomach. So what's this? How does the stomach get up there?
Unless they've had gastric sleeve pulls and
gastric pull-up.
Yeah.
And what does the surgeon do to the rib to get to the esophagus to remove it before the gastric pull-up? They take some of it away.
Yeah, remove part of it.
That is the hallmark of a gastric pull-up. Yeah. So you've got rib, surgical resection, stroke, deformity, and you've got a thick-walled viscous that looks a bit like the esophagus, but it's too thick-walled. That's a gastric pull-up. Yeah.
Okay.
And the other thing to note, whenever you look at achalasia or gastric pull-up in the exam, tell the examiner that there isn't any evidence of aspiration pneumonia. Or if there is, tell them that there is. So that one, if you saw that in the exam now, you're going to nail it, aren't you?
Yes.
And you're also going to nail the numbering of the ribs.
Yeah.
The thing about numbering the ribs, you can't do it quickly. You've got to do it slowly. You've got to go one. Can you see my arrow, by the way? Yeah.
I can. Yeah.
Yeah. 1, 2, 3, 4, 5, 6. There you go, 6. But do it slowly so you don't kind of jump more than one rib. This one you smashed. That was brilliant. That was well done. CPPD, hook-like occupied, second, third, to a lesser extent, the fourth metacarpal heads, TFC calcification, lots of degenerative disease, which is typical of CPPD. And in this case, the hook-like osteophytes suggest hemochromatosis. This one, you're not the only person to stumble with this one. The patient has clearly got middle and lower lobe collapse. There's some consolidation in the left lower and right upper lobes, but there are no muscles, and all the muscles have turned to fat. And these patients unfortunately die before they get to the age of about 30, and that's because they've got muscle atrophy and the muscles turn to fat, and it's X-linked recessive. Eosinophilic pneumonia, you smashed that one. That was good. You could do a CT scan just to characterize it. In the old days, that patient may have had a biopsy, but actually what you really need to do is you need to do a blood film to look for peripheral eosinophilia. But this patient did have peripheral eosinophilia. They don't all have it, but this patient did. And you do an HRCT rather than anything else, I think. This is one of my favorite films. That is HPOA or HOA. Why do we call it HOA and not HPOA?
My understanding was if it's pulmonary related, then you call it HPOA. But if the cause is
that's probably true. It's actually called HOA now because there are more causes than just pulmonary. Yeah, but that will give the patient clubbing. And have you ever seen that in the clavicles?
no, it's the first time seeing
No,
it.
no, I've never seen it before. So what do you do if you've never seen something before?
Compared to previous.
Yeah, compared to previous, yeah, that's good. That's always a good suggestion. Go and ask a colleague, maybe.
Yeah.
Yeah. Are you allowed to say that in the exam?
I guess you can because you're being a safe radiologist.
Exactly. But you're not allowed to do it for every question though.
Yes.
So you're only allowed to do it for 1 or 2 questions. But yeah, you're demonstrating that you're a safe radiologist. None of my colleagues had seen this before, so I Googled it, and it's very well described, but it's quite rare. But it's the first time I'd seen it. And then this one is just ischemic bowel, portal venous gas, ascites, yeah, and or is that pleural fluid? What do you think? Is that ascites or pleural fluid?
That looks like pleural fluid to me on the
You know what?
right
I
side.
think there's both. I think it's both. So that's
Oh,
ascites, and that is pleural fluid.
Yeah, that's the bit I was referencing to.
Yeah,
Sorry.
so it's a bit of
Yeah.
both, actually. A bit of both. So portal venous gas, we've got a heavily calcified celiac axis, aorta, superior mesenteric artery, and then, as you rightly say, pneumatosis. So the patient's got ischemic gut. This one, if this was a malignancy and that was eroding the rib, it would erode the rib and it would just vanish. But this is preserving the cortex of the rib and it's scalloping it. And that's the hallmark of a benign lesion. And we've got the incomplete border sign, so it's well defined, and then it's poorly defined, well defined, then poorly defined. And this is a neurofibroma or a schwannoma. So underneath the rib lives the vein, artery, and nerve, and this is a neural tumor, nerve sheath tumor. Okay, most likely. And then the last one was the subarachnoid hemorrhage. I think that was it. Yeah, brilliant. Okay,
Thank you.
done. Well done. So the ones you could have done better on were the gastric puller, and then this one. If you've never seen one before, you might think it's malignant, but that's actually a benign lesion because of what I've mentioned.
Sounds, yeah, makes sense. Thank you.
Okay, good luck. And
Thank you.
please don't send me a John Lewis voucher. I'm only saying that to joke with you.
Yeah.
All right, but do smash it in the exam.
Thank you.
Okay, over to candidate 3, please.
Good evening, sir.
Hello.
Hello, how are you?
I'm very well. Very well, thank you. Right, so Bhumika, are you going to start the timer?
Yes, I've just started it.
Lovely. Okay, so I'm going to just give you the controls. And again, if I ask you to stop the mouse, it's because I need the controls, okay? Yeah, got it. Fire away. This patient is a middle-aged man who's febrile and sick.
Yes, I have been presented with a frontal chest radiograph for an adult male patient with history of febrile and sick. I cannot detect any obvious abnormality, so I will go through my checklist. I can see that there is tiny nodules scatters through both lung fields. I cannot see any mass lesions. I can see that the costophrenic angles appear clear. I can see that there is opacity seen in the left hilar area.
Just point that out using your mouse.
This one.
Yeah, okay. Don't worry about that. That's the hilar regions are normal. Just tell me about the nodules.
Yeah, I can see that the nodules, they are look small in size. They are scattered.
What's the diagnosis?
Yeah.
What's the diagnosis?
They are small in size. So I'm thinking about varicella pneumonia.
No, patient's not well, febrile, and the nodules are no bigger than 3 millimeters.
They can be due to metastatic deposit.
Possibly.
Yeah.
But he's got a fever.
It could be due to atypical infection, atypical pneumonia.
Which one?
Klebsiella pneumonia, maybe.
No, that gives you a lobar pneumonia with a bulging fissure. This is miliary TB.
Miliary TB, yeah.
Yeah. So in the exam, you must say miliary TB. This is one of those things that even if you're wrong, you are right, because you've got to mention miliary TB until proved otherwise, yeah?
Okay.
Okay, no problem. Let's have a look at this next one. This patient is complaining of a cough.
Yes, I have been presented with frontal chest radiograph for an adult patient with history of cough. I can see that there is decrease in the size of the left lung in comparison with the right lung. I can see that there is a mass lesion noted in the left hilar area, causing a Villing sign of the left lung and also causing rounding of the ribs. Appearances are those of left lung upper lobe collapse, mostly
good.
due to the mass lesion that's seen in the right hilar area.
Left hilar area, but don't worry, that's fine. Yeah, left hilum.
Yeah. So my next step is fast track chest CT scan with IV contrast for better characterization of this.
All of that is absolutely right. So you put the patient through a CT, etc. Can you see anything else on the film?
I will look if there is any metastasis process seen elsewhere in this film. And also I will see if I can see that there is here in this cut, I can see that there is missing rib causing destruction by the mass lesion.
Just show the audience that lesion. Yeah, well done. And can you see the incomplete border sign of a soft tissue mass underneath it?
Yes, I can see here. Maybe this is the mass lesion with the incomplete border sign.
Yeah, incomplete border sign. Now, unlike the schwannoma of the rib, which candidate 2 looked at, this rib is destroyed, whereas the other case, the rib was scalloped. Yeah. So this patient's got left upper lobe collapse due to a hilar tumor, and we've got a rib deposit. Yeah, well done. Just hang on 1 second. I'm just gonna. There you go. Sorry. Do carry on. This patient is breathless.
Yes, I have been presented with axial images of chest CT scan. I can see that there is evidence of interlobular septal thickening associated with ground glass appearance, giving the appearance of crazy waving sign. I cannot see any pleural effusion, and there is no significant lymphadenopathy seen in the mediastinal or both hilar areas.
Diagnosis?
My first diagnosis is pulmonary alveolar proteinosis.
Okay, good. Let me take control. Okay, this patient is complaining of knee pain.
I have been presented with right knee radiograph, AB and lateral views. I can see that there is lucent, ill-defined lesion seen in the lateral. Yeah, sorry. This area.
Okay.
Yeah, I can see that there is ill-defined lytic lesion seen in the distal right femoral epicondyle area.
Is that lytic, or is the surrounding bone sclerotic?
It's surrounded by sclerotic bony lesion.
Yeah, okay, I accept that. That's good.
Yeah, this lesion looks ill-defined with a wide zone of transition. I cannot see any matrix within this mass lesion. Also, I cannot see any periosteal reaction. There is no cortical destruction. In reviewing also the lateral view, also I cannot see any extraosseous mass lesion. Okay, so my impression for this is aggressive bony lesion. my differential diagnosis, it could be due to primary bone lesion,
Yeah, such as.
such as osteosarcoma.
Yeah, that's
Uh,
what it was. That's what
yeah,
it was.
my next step is to do MRI. Yeah,
Yeah, go on. What would you do?
MRI for upper and lower joint.
Yeah, good. And what else would you do? Just
Uh,
ignore this for the moment.
yeah. An MRI.
Yeah, MRI above and below the lesion. Yeah,
Yes.
would you do a CT chest?
Yeah, for staging.
Yeah, good. Okay, and then referral to a specialist bone center for biopsy. Okay, have a look at this next one. This is trauma in an elderly patient.
Yes, I have been presented with lateral cross-table cervical spine and also frontal AB view. I can first I want to check the alignment of the vertebral spine due to the history of trauma. The first, second, third vertebral cervical vertebra is not clearly visualized. However, I can see that there is malalignment seen between the C3 and C4 vertebra. I can see
Okay.
that there is.
Yeah, if I told you that everything you've said is correct, you've got degenerative change in the cervical spine. The upper cervical spine is poorly visualized, but the visualized spine can't see a fracture, and all of the slight loss of alignment is due to degenerative change. Can you see anything else on the film?
Yeah, I will look for any evidence of fracture in the posterior elements. I
Yeah,
cannot
they're
see.
okay. In fact, there's no fracture.
Okay. I can see that there is enlargement of the soft tissue seen surrounding the neck, seen here and here. There is enlargement of the soft tissue surrounding the cervical spine. But
Okay.
yeah, but in the
No,
lateral, yeah,
I think this thing here is making the neck look fatter than it really is. It's symmetrical, but the patient's in a soft, restraining collar on the table, cross table. So look below the neck. What can you see?
okay. And now I am checking the bones in the vertebra and sorry, in the ribs and the
Yeah, the
clavicle. I
bones
cannot.
are the bones are okay. So where else are you going to check?
Uh, lung window.
Yeah,
Sorry, so both lungs. I want
yeah. Have a
to.
look at the lungs.
Yeah, I cannot see any specific finding within both lungs, but I think here in this area I can see that there is soft
What
tissue
would you do
mass lesion.
next?
Full dedicated chest radiograph, then chest CT scan with IV contrast.
Okay, what's the diagnosis?
The diagnosis, I can see that there is vessels passes through this mass lesion, make it mediastinal mass lesion, and as the mass cannot extend above the clavicle, I think this is anterior mediastinal mass lesion.
Could it be a lung lesion
Yeah,
invading the mediastinum?
yeah, the other differential, yes, it could be. However, I can see if the border is complete or not. If there is incomplete border, it will be extrapulmonary. If it is complete, can we
Well,
enlarge?
it could be a pulmonary lesion that's invading the mediastinum, couldn't it?
Yes.
And most likely, it's going to be a bronchial carcinoma, which is what it
Yeah.
was. Okay. Have a look at this one. This patient's got a swollen shin.
Yes, I have been presented with frontal and lateral radiograph for the leg. There is no marker. However, I can see that there is a ill-defined mass lesion seen in the shaft of the tibial bone. This mass lesion causing expansile of the bone, and also I can see that it should like a soft tissue component in the lateral view. I cannot see any matrix within the mass lesion. Also, there is no I think there is no periosteal reaction, and there is no cortical destruction. I cannot see any similar mass lesion.
I think anteriorly there is some cortical destruction just there, see it?
Yeah,
But everywhere else, it looks like a soap bubble lesion, really. But that's just destroyed there. Everywhere else, it looks like a big soap bubble. Do you know what the diagnosis is in that particular position?
if the patient is young in age, I will think about adamantinoma lesion.
And do you think the patient's young?
No, this is an adult patient.
Well, yeah, but do you think the epiphyses have only recently fused?
Yeah, I think there is like a physial line. So I
Yeah.
think this is a young patient.
So it's an adolescent stroke young adult, so it all fits. That was an adamantinoma.
Yeah.
Well done. Okay. Have a look at this one. Tell me what's going on there.
I have been presented with abdomen radiograph for an adult patient. Can we change the contrast of the image? Yes. Yeah, the main abnormality, I can see that there is abnormal configuration of the pelvic bone. The pelvic inlet is look like champagne glass, and I can see that there is tombstone of both iliac bones.
Yeah.
I can see that the vertebrae appear normal. There is no evidence of fracture. There is preserved of the alignment. There is no abnormality seen within the ribs.
Put it all together.
My top differential diagnosis for this case is a case of achondroplasia.
Yeah, good.
So I will ask for the rest of the images to see if there is any other associated finding.
Okay. Have a look at that one.
Is this a different patient?
Different patient. One slice. I want you to give me the exact diagnosis.
Yes, I can see that there is left-sided pleural effusion in this MRI scan. I can see that there is mass lesion seen anteriorly in the chest wall, and I can see that there is metastatic deposit seen subpleural in the right lung. So
Good.
my impression, could be a chest wall malignant mass lesion associated with right pleural effusion and metastatic deposit.
Okay, this is an elderly man who has got abdo pain.
I have been presented with a frontal abdominal radiograph for an adult patient with history of abdominal pain. I can see that there is dilatation of the small bowel, including the proximal jejunum and distal ileum.
Okay.
I cannot see any pneumatosis intestinalis within.
What would you do next?
In this case, I will check the hernial orifices for this patient to see if there is any evidence of hernia. Second,
Okay.
I will,
Yeah. Anything else? Would you go on and do a CT?
sorry, what?
Would you go on and do a CT?
Yeah.
Yeah. So let's show you the CT. Oops, wrong one. Sorry. Do you want to scroll through that?
Yes. So I have been presented with chest CT scan for the same patient. I can see that there is a nasogastric tube.
Yeah.
Okay, let me scroll.
Yeah, go on, you scroll.
Yeah, I can see that there is a gas, tubular gas structure seen within the liver. So
Yeah, whereabouts? Where is the gas in the liver?
I can, sorry, the images are jumping. So I
I'll
think,
tell you what. I'll scroll for you. And
yeah,
okay.
thank you.
So, can you see gas there?
Yeah, the gas, I think that this gas is not reaching the peripheral of the liver. So most
Okay.
probably due to biliary.
Yeah. Okay. So it
So
could be gas in the biliary tree.
yeah,
Yeah.
there is gas in the biliary tree. First of all, I will check the gallbladder to see if there is gas within the lumen of the gallbladder. Then I will check the bowel to see where is the level of obstruction, and I am looking for any evidence of laminated calcified lesion, such as
Okay.
gallbladder stone, causing obstruction as a gallbladder stone ileus.
Yeah. Now, I couldn't see a gallstone either.
Yeah,
But
but I can see that there is hernia seen in the right side.
yeah.
This hernia,
And the
I think
question is it inguinal or femoral?
I think this hernia is causing compression on the right femoral vein. So most probably this is a femoral hernia rather than inguinal.
Excellent. Really good. Well done. So just to let the audience know, there's the left femoral vein, there's the right femoral vein, and it's squashed. And therefore, the bowel must be going in the femoral canal on the right-hand side to cause that squashing of the femoral vein. And inguinal hernias tend to be overlying the pubic tubercle. Yeah, well done. That was really good. Okay, I'll show you another. Okay, this is a middle-aged female who has a routine chest X-ray after visiting her GP with a cough.
I have been presented with a frontal chest radiograph for an adult female patient with history of cough on routine GB visit. The most obvious abnormality that I can see that there is lesions seen overlying both lung shadows. This lesion appear or showed higher density. It could represent calcified density. I can see that the lesions, I cannot separate them from the, they can be seen between the ribs. So they are not arising from the ribs. And I can see that in the left side, they are extending toward the left hemidiaphragm. I can see there are lesions seen overlying the left hemidiaphragm. I can see that both breast shadows are preserved. I cannot see any pneumothorax, pneumomediastinum. Also, there is there is obliteration of the left costophrenic angle, which could represent pleural fusion.
Okay, so what do you think's going on here?
I think these are calcified lesion that could be extrapulmonary, rather than, yeah,
Yeah, they definitely are extrapulmonary.
yeah.
Do they look like does it look like holly leaf calcification?
I don't know about the holy leaf
Okay.
calcification.
Have you ever seen this before?
No, no.
Okay, this is asbestos related pleural plaque.
Okay.
Yeah. So asbestos related pleural plaques, they tend to be more calcified at the periphery. Okay. And they mean that the patient's been exposed to asbestos. Okay. Now,
Okay.
what's unusual about this patient?
Sorry.
What is unusual about this patient?
That the lesions are the female patient, there is work occupational hazard for the asbestos.
Yeah. So what do you think? How do you think this lady got exposed to asbestos?
It could be from painting of in old homes or something like that.
So in fact, her husband worked as a shipyard worker,
Ah,
and she was exposed to the dust because it was on his clothes every day for the 35, 40 years he worked there. So she was exposed to the asbestos fibers that were on his clothing. Okay, have a look at this next one. How are we doing for time, Mika?
We've just crossed the 20-minute mark.
Okay, good.
yeah.
Seems so impersonal, but I've got to call you candidate number 3.
Yeah, I can see that I have been presented with left forearm AB and lateral views. I see that there is generalized expansile lesion seen involving the left ulnar bone that causing deformity of the ulnar bone. I can see that there is also positive ulnar variance is noted. The radial bone
What's
appear
the
normal,
diagnosis?
and diagnosis on the top of my differential diagnosis, it could be due to increased trabeculation, and I'm thinking about Paget disease.
Paget's. That's all I
Yeah.
wanted you to say. So in the exam, if you know what it is, knock it for 6. But the examiner might want you to just knock it for 6. And some examiners may not want you to knock it for 6. I would want you to knock it for 6.
Yeah.
Yeah. But you have to understand what the examiner that you've got wants, because the examiner you get in the exam might be slightly different to me, and they may want lots of description. But I kind of want you to just knock it for 6. Yeah, that's a classical Paget's in an unusual position. How did you think you did?
I was a little bit nervous at the start, but I think, yeah,
You were, yeah.
better
But how do you
than
think
my
you did?
last exam.
I thought you did really, really well. Okay,
Thank you. Thank you.
you didn't start particularly well, but then you got a lot better, and you got a lot better quickly. So the examiners will forget about films that you haven't done particularly well on, because you've picked up and you've done really well. So I'm going to go through those cases. Not necessarily in the order in which you've done them, but can I just take over the control of the mouse? Yeah, great. Okay, so this is Paget's disease. It's absolutely classical Paget's. We've got thickening of the bone, thickening of the cortex, coarsening of the trabecular pattern, and we've got bowing of the bone, and that was Paget's. This one I showed you was osteosarcoma of the femur. Okay, and you can see this sclerotic edge. There's a bit of a cortical destruction just here. Look at the sclerosis of the femur compared to the tibia. And that is actually normal bone, although it looks loosened. And it's because everywhere else is sclerotic. And we've got this periosteal reaction. And that turned out to be an osteosarcoma. The very first one I showed you, that's miliary TB. So if you see lots and lots of nodules which are 3 millimeters or less in size, and the patient's got a fever, the first thing you should say is miliary TB. Have you got that? Yeah. Miliary TB.
Yes.
Most important. yeah, you smashed this one exactly as you would expect in the exam, and you suggested, send the patient for a CT scan, the lung cancer multidisciplinary team, but you've still got to keep on looking at the rest of the film. So even though you've got everything right, tell the examiner you're looking for evidence of metastases, and then there you have it. And see how different that is from the schwannoma, which was eroding the undersurface of the rib, which was scalloping the rib. This is actually destroying the rib. You can see the rib, then it's gone. You can see the rib, and it's gone. Yeah. So that patient's got a rib lesion. I didn't show you the CT, but I'll just show it to you for effect. So that those lines are just to show you why you can see the left upper lobe collapse on the lateral, because it's tangential to the interface. But on the PA film, you can't see the interface because it's at right angles. Okay. And then we've got a mass lesion in the hilum, and then there's your mass lesion over here. The green line is tangential to the interface between the lesion and the lung, therefore it's sharp. And the orange line is at 45 degrees to the lesion and the lung. That's why it fades laterally. So that's the basis of the incomplete border sign. This one you did extremely well. Small bowel dilatation. Don't forget, guys, small bowel dilatation, 3 things. It could be mechanical obstruction. It could be paralytic ileus. And the thing that everyone forgets is ischemia. So whenever you see small bowel dilatation, think mechanical obstruction, paralytic ileus, and ischemia. The next thing to do here is a CT scan. And as you rightly say, you're looking for a gallstone ileus because you can see gas in the biliary tree. But don't forget, gas in the biliary tree as you get older could be more common anyway for other reasons, such as a lax sphincter of Oddi. And there was no gallstone ileus here. So I looked for a gallstone ileus, I couldn't see one. And then we can see a hernia. And because the femoral canal is very small, and because it's got 3 structures in it, an artery, a vein, and a nerve, it's the vein that gets compressed. Okay. And the vein gets compressed because it's a femoral hernia. There you go. You can just see it there. Compare it to the other side. So there's the femoral vein on the left. There's the femoral vein on the right. Therefore, it must be a femoral hernia. And it's not an inguinal hernia because 1, it's a femoral hernia, and 2, it's not overlapping the pubic tubercle. And femoral hernias are much more important because obviously patients will strangulate much more readily with a femoral hernia. This was a cruel one, really, but whenever you look at a cervical spine X-ray, carotid calcification, I was giving you lots and lots of hints that there was no bony injury. Always look at the lungs, and this patient had a bronchial carcinoma. One slice gives the whole story. Breast prosthesis on the right side indicates breast cancer. We've got a sternal deposit, and we've got a large pleural effusion with 2 pleural deposits. So it's breast cancer with bony and pleural metastases. If you've never seen this before, just lock it away in your memory banks, smash it in the exam. This is what asbestos-related pleural plaques look like. Holly leaf calcification, very typical. And very unusually, this is a female, and she's got it from her husband's occupation. So always worth remembering that. You smashed this one out the park. This was very good. Alveolar proteinosis. It's so classical, I would not regard anything else as causing this. but of course there are lots of causes of crazy paving, such as interstitial pulmonary edema. Okay, that tends to be less marked than this. Early infection, pneumocystis, viral pneumonias, lipoid pneumonia, the list goes on and on and on and on. But actually, if it looks like this, it looks like a map of the world, geographical, it's going to be alveolar proteinosis, which is what this was. That's an adamantinoma. Again, it's got benign and aggressive features in the same lesion. It's expansile. It's got sclerotic margins. It almost looks like fibrous dysplasia, but then the cortex has gone anteriorly. Adamantinoma and achondroplasia. So the interpedicular distance should get bigger. So it should go out like that, but it doesn't. It goes in like that. And there's the interpedicular distance there. So these lines should actually diverge. Yeah. So that's one of the features that you see. You get lateral film. You get the posterior scalloping with spinal stenosis. I didn't show you this. The champagne glass pelvic inlet. Just there. So the champagne glass pelvic inlet and the squaring of the iliac blades. And this is achondroplasia, posterior scalloping. Yeah, very well done. I thought you did really well. So that's a great lesson, guys, in candidate 3. Sounds so impersonal, but candidate number 3. He started off, could have done better. Wasn't bad, but it could have been so much better. But he ignored that and he just carried on and he did really well. So in the exam, you might start off with a bad film, but you just forget about it and just move on.
Thank you,
So
sir. Thank you.
that was very well done. Okay, so we've got candidate number 4. Please.
Hello, sir. Hello.
Hello.
How are you, sir?
Hi, candidate number 4. I'm very well, thank you. Are you ready? And is Bhumika able to start the clock?
Yeah, I've just started it.
Great stuff, thank you. Okay, so Bhumika, have a look at those hands.
Okay.
Oh,
So
let me give you remote control.
okay. Okay, now I have the control. Okay. So I'm provided with the radiograph of both hands, frontal projection of a skeletally mature patient, in which I can appreciate that there is an area of soft tissue calcification is noted, predominantly in the
Can you point it out to the audience?
yes, over here, along the
You may
carpometacarpal.
need to click before you move your mouse.
Okay, so now can you see it?
I can now, yeah.
Okay, it's over here. It's very symmetrically and bilaterally. And I can also appreciate that there is periarticular osteopenia that is noted along the wrist joint as well as in the metacarpal phalangeal joints. There is some soft tissue calcification over here as well.
Yeah,
And
good.
I can also appreciate that there is an acrostealized tuft resorption is also noted along the index finger
good.
distal phalanx. So keeping in view the acrosteolysis and the soft tissue calcification, this it could likely be a case of systemic sclerosis, scleroderma, and I would like to go further
No, that's
investigation.
fine. I'm going to show you another. No, that's fine. That's okay. You've got that. I was going to show you the lungs, but I don't think I've got them.
Okay.
Have I? I'll just scroll for you.
Okay, so this is of the same patient?
Yeah.
Okay.
What do you think about the lungs?
Okay, so in the basal segments, I can appreciate that there is a subtle ground glass haze with there's prominence of the interstitial markings. The inter and the interlobar septal thickening is also noted in the basal segments. And if I could have,
Sorry, yeah, go on.
and the esophagus is also dilated and patulous. So this
Put
is
it all
basically
together.
interstitial lung disease with the patulous esophagus and the findings on the along the hands as well, likely a case of systemic sclerosis.
Good, excellent. Okay, have a look at that one.
Okay. Should I scroll or are you going to
Please
scroll?
do, yeah, please do. Sorry.
Okay.
Just move it up and down. That's it. That should work.
Okay. So I'm provided with the coronal sections of HRCT of a skeletally mature patient, in which I can appreciate that there are multiple centrilobular emphysematous cysts noted in bilateral lung fields, with the predominantly in the apical and the mid lung
Did you say
segments.
centrilobular?
Uh,
Are they a bit random?
I would like to review them on the axial if it is available as
Okay,
well.
I'll show you the axials. Just let me take over for a second.
Okay.
Let me take over for a second.
Okay, I'm not moving the mouse.
Okay. Okay, so you go ahead.
Okay. Okay.
Are they
So-
random or centrilobular?
No, they're random and they're
They
bizarre
are.
shaped as well.
And are they different shapes and different sizes?
Yes, and
Any
slightly.
nodules too?
Yes, they're nodules too. So if there is any history of smoking, this could be LCH.
Yeah. And which bits of the lungs are less involved?
The bases are less involved, especially the costophonic angles.
Good.
It pairs the those areas.
Excellent. Well done. Okay, I'm going to take over the control again.
Okay, I'm not touching the mouse.
That's okay. Fine. I think it has a problem with the scroll button. Okay. Now, this was a patient who underwent a barium meal, and the history was weight loss and loss of appetite.
Okay.
Just look at that one.
Okay, so I'm provided with the spot image of the barium meal examination, and in which I can appreciate that the barium is outlining the cardiac end and the body and the pyloric canal, and it seems to be passing fine through the pylorus into the duodenum, and it is opacifying the duodenum as well as the duodenal loops are also noted. However, I can appreciate that there is slight luminal narrowing noted along the area of the lesser curvature, and I would like to confirm it on the other views if they're available. And this area over here, this, and if I can have other views, I can also confirm it if this changes with the peristalsis. Otherwise, this could be some.
I'm sorry about that. I was just having a sneeze. I do beg your pardon. Yeah, that the gastrointestinal tract is completely normal.
Okay.
So what's the cause of this patient's weight loss and loss of appetite?
Weight loss and loss of appetite. Other than that,
Look above the diaphragm.
I can, the retrocardic area appears to be not as.
What's this thing here?
I think this is the left lower lobe collapse. There's a
Yeah,
retrocardic opacity.
excellent. Excellent. Next case.
Okay, so
This patient's got abdo pain.
okay. I'm provided with the X-ray abdomen, radiograph abdomen of a skeletally mature patient, in which I can appreciate that there are multiple rounded opacities are noted in the right and the hypochondrium, as well as in the lumbar region
Just point those out.
over here. These,
You need to click before you move your mouse.
sorry,
Yeah,
over
that's
here.
okay. That's fine.
These ones over
That's
here.
feces. It's normal.
Okay. Can I change the window a little
Please
bit?
do.
Because I cannot clearly
So
see.
if you use your left mouse, left click, and then
Okay.
yeah, that's it. And then press down. That's it. Good. Move up. That's it.
Oh, sorry.
It's okay.
Okay. I cannot see anything abnormal. Okay, I'm looking above the diaphragms now. I can see that there's a rounded opacity in the
Okay.
right one over
What do
here.
you think that is?
It's likely an intrapulmonary lesion, as it's around within the limited evaluation. It seems it's surrounded by the lung parenchyma, so it's intrapulmonary, and it is likely a mass. And I would like to further evaluate it by
Good.
going.
Excellent.
Imaging.
This patient presents with a stroke.
Okay. So I'm provided with the frontal radiograph chest of a skeletally mature patient, in which I can see that there is a pacemaker with that is there are two dual chamber. One is in the right atrium and the other seems to be in the right ventricle. And the patient had stroke. Okay, so and there's slight airspace or shadowing is noted in the bilateral basal segments. So over here,
So
over here, and this over here. So it could be a case of
what can you
aspiration
see on a
pneumonia.
chest X-ray that might be implicated in a stroke?
Patient could aspirate, so patient could have an aspirational
Yeah,
pneumonia.
good. That's very good. Well thought. Yeah. Anything else?
Other
Anything
than
that could be the cause of the stroke
that,
on the chest X-ray?
there's a slight curvilinear calcification. I think it's in this region over here and along the heart.
Okay,
So
what's that?
it could be a valve calcification that could be that might be the site of that might be throwing the emboli, causing that stroke into this.
It's not valve calcification, but it is the source of embolus.
Okay. Valve calcification.
So is this patient well nourished?
Well nourished.
Which is a polite way of saying overweight.
Yes, I think so, because there's a lot of soft tissue along the
Yeah.
ribcage.
So if they are overweight, they're entitled to have a pericardial fat pad, aren't they?
Yes.
So this is the pericardial fat pad,
Yes.
but the heart ends about here. So
Okay.
what's this calcified?
So this could be calcification of the ventricular aneurysm.
Excellent. That's what it is. Brilliant. Okay. Okay. What's the diagnosis here?
Okay. I'm provided with the lateral radiograph skull of a skeletally mature patient. in which I can appreciate that there is a lucent area that is noted along the anterior aspect of the frontal and the parietal bones. With slight increased density that is noted along the lower aspect of the face and the mandible and the maxillary and the vitreous part of the area. So this could be a case of I think it's lucent and as well as
So you've got a well-defined demarcation between that lucency and that lucency,
yes,
and then a well-defined demarcation between that lucency and that normality.
yes,
So,
Right.
in other words, there are two areas of lucency. One is larger than the other one, and then it's being projected one through the other.
I think it's I think it is
What would you call a well-circumscribed area of osteoporosis?
osteoporosis circumscripta.
Yeah. Diagnosis? What causes osteoporosis circumscripta? Common in the UK, not so common in
Vitamin D deficiency.
No. It's Paget's disease.
Oh yes,
Okay. So very common in the UK. Okay, this patient's got a sore mouth and jaw.
Okay. So I'm provided with the OPG of a skeletally mature patient, and the patient has sore mouth. I cannot appreciate any definite fracture line. The teeth are also aligned normally.
Okay.
The mandible is also articulating normally. There's no TMJ dislocation or anything like that.
So what's the investigation? What's the examination?
This is an OPG.
Okay. And what does the radiographer tell the patient to do during an OPG?
They tell the patient to make sure that the tongue is along the floor of the mouth so that it doesn't
To clench
create
their
an
teeth,
artifact.
yeah? Teeth
Yes.
together. Yeah,
Yes.
like that. And are those teeth together?
No, they're not.
So why?
The patient had sore mouth, so there could be an can't find any
So
striking.
the teeth are not together.
Yes.
That's the
Okay, it's
bone where the
yes, it's out
mandibular
of
condyle should sit,
yes,
and it's
yes,
now forward. That's forward as well. So we've
yes.
got bilateral
Bilateral TMJ dislocation.
TMJ
Yes.
dislocation. Yeah, well done. Okay, this patient is suffering from high blood pressure.
Okay, so I'm provided with the radiographed chest of a skeletally mature patient, in which I can appreciate that I cannot appreciate the aortic knuckle properly, and there is bilateral inferior rib notching that is noted along 1, 2, 3, starting from third, fourth, fifth, sixth, seventh, and likely eighth bilaterally from 3 to 8 ribs are involved. So this is likely a case of coarctation of aorta, and I would like to compare it with the previous imaging, or if the patient just come out now, so we would go for the CT angio or MRA, whichever one.
Okay, if that's coarctation, what's this thing here? What's that thing there? What's that thing there? What's that thing there?
Okay, so these are basically pleural-based lesions that are making an obtuse angle with the chest wall. So these could be neurofibromas.
Yeah. And so why can't you see the neurofibromas causing the rib notching here?
Because the X-rays are passing through them directly, not along, I think, in the tangential view. So that is why they're
Exactly.
more
So
easily
it's
picked from
en
it as well.
face. The French call it en face,
Yes,
and whereas in profile you can see them there.
yes.
So the appearances are those of neurofibromatosis. There's a neurofibroma there as well. Now, third question. Why do patients with neurofibromatosis get high blood pressure?
Why do they get high blood pressure? Because I think it causes renal artery stenosis as well. So
good.
so that
Renal artery stenosis, pheochromocytoma.
yes,
They can also get coarctation.
yes.
There's a higher incidence. And then, of course, they could get essential hypertension like 95% of the population. Okay, it's a very old film which is cracked, and I've scanned it in. But tell me what the diagnosis is.
It has got spade-like distal phalanges, so it's a case of acromegaly.
Excellent. Yeah, very good. And
there is also the
no, that's it. That's fine. Yeah, sorry. What were you going to say?
No, I was just going to explain the other findings along the proximal phalanges.
Yeah, that's fine. Let's
Yeah.
go through that again then. Sorry. You've smashed it to the boundary, but go on. You want to go for more? That's fine. So
I just wanted to say that along the phalanges as well over here, they're shaped like spades, and
yeah, that's right. That's right. Yeah, and note also that there's increased cartilage growth.
yes.
Acromegaly will give you increased cartilage growth. Yeah, yeah. Well done. And then this patient is complaining of ankle pain bilaterally.
Okay. So I'm provided with the radiograph
I've only
ankle.
got. I've only got the left ankle, I'm afraid.
Yes. So
But it's bilateral, and the right ankle looked identical to this.
okay. So I'm provided with the lateral view as well as the frontal projection, and the ankle joint is the distance between the tibia and the talus and the fibula and the talus. It appears to be intact. There's no any widening or joint.
Okay, so I can't see anything wrong with this X-ray. Okay, and the same was true of the other side, but the patient was in excruciating pain laterally. What would you do next? Patient's a jogger, which
So
I conveniently didn't mention.
okay, so it could be stress fracture. So I would like to go for bone scan and for follow-up.
You could do a bone scan. What's better than a bone scan?
MRI?
Yeah. Okay, you control the MRI.
Okay.
Roll through it.
Okay, so I can see that there's an altered MR signal intensity area that is noted within the distal aspect of the fibula that is linear and likely representing a fracture, and surrounding edematous changes in the soft tissue as well.
Would you be worried about the surrounding high signal change? In other words, would you be worried it might be a malignancy?
I think I would.
A yes or a no, not a maybe.
Okay. What's the age of the patient?
28.
I don't think so.
Good. That's the correct answer. You shouldn't be worried about it. This is all due to a stress fracture. Well done.
Yes.
Okay. How are we doing for time, Bhumika? We'll keep on going anyway. Have a look at this one.
Okay. So I'm provided with the CCT chest from the jaw skeleton. I can appreciate that there is mild ascites noted along the liver, and mild pleural effusion is also noted bilaterally.
Yeah. Yeah.
It's not going down anymore.
Sorry, that's my fault. Go on, you take over, click and then move.
Okay.
Yeah, that's it. Sorry, it's a bit fiddly. In Teams, you will have independent use of the mouse, but it's not like that in Zoom.
Okay. So in the first look, I can appreciate that there are large enlarged lymph nodes that are making conglomerate nodal masses that are insinuating among the vessels. They're in,
Yeah.
and
We've just crossed the 20 minutes mark.
Okay, thank you.
and it's extending all the way from the celiac axis down below.
Yeah.
So and there's a transplanted kidney as well in the left iliac fossa.
Yeah, good.
Okay, so and
What's
there's also
your-
thickening, circumferential thickening over here. So this could be lymphoproliferative disorder secondary to the kidney transplant. And I would like to also I would like to review the native kidneys as well.
Yeah, go
These are
on.
atrophic over here. So
Yeah, well done.
So this is likely a case of lymphoproliferative disorder secondary to the post-renal transplant.
Okay. Now, it's very late. The bell has gone, and I want a vote from the audience. Should I give candidate 4 one more case? Yes, 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 yes. So I'm going to give you one more case.
Okay.
Hope that's okay.
Yes, it's okay. Oh,
Right. Here we
it's like
go. Okay, have a look at that one.
okay. So I'm provided with the chest radiograph frontal projection of a skeletally mature patient, in which I can appreciate that there is an obesity that is seen in the right.
To show the audience with your
Okay, this one.
cursor. Yeah,
In the
good.
right middle and the lower zone that is obscuring the right cardiac border and part of the right diaphragmatic dome as well.
Okay,
So
good.
as it is, there's loss of ciliate sign of the heart as well as the diaphragm. So this is likely an anterior mediastinal mass, and I can also confirm it on the. I would like to confirm it on the lateral view as well.
Show me where it is on the lateral.
Okay. I think it's this one.
That's
this,
it. Yeah, well done. What would you do to confirm its presence and the diagnosis?
I would go for a CCT chest to confirm my findings.
Let me just take the mouse.
Okay.
So Amruth Vanahali wants me to show you another case, but I think we'll leave this one. This will be the last one.
Okay.
Nice try, Amruth. Okay, scroll through that.
Okay. So I provided with the CCT chest, mediastinal window. Okay, so I see, as I've explained the findings in the X-ray, there's an anterior mediastinal mass that
What's the density of that mass?
it's a fluid density. It's
Okay.
at
What's
least
the
from
diagnosis?
I would like to measure the HU as well to confirm my findings. So
Yeah.
it could be
It had a Hansfield value of about 3.
okay. So this confirms that it's a fluid density lesion, and so this could be a pericardial cyst or
Yeah. Another word for another name for it is a spring water cyst, because literally when they drain it's like fresh water coming out. So they call it
Okay.
spring water cyst, pericardial cyst. Okay, how do you think you did?
I think it went okay. It could have been better. The pages one I just blacked out on that. Otherwise, I could have done much
Sorry,
better.
which one did you black out on?
The pages one, osteoporosis
Oh yeah,
subclinic.
don't worry. But the great thing is, when you do the exam and you see osteoporosis circumscripta, what are you going to do?
I'm going to smash it with a 6.
Excellent. Okay. So there's no such thing as a bad film, because you guys and the audience will learn from all the films that I've shown. And if any of them come up in the exam, you just knock them for 6. Yeah.
Okay.
You may not have seen them before, or you may have struggled, in the nervousness of the event, but it doesn't matter. When you see it in the exam, you knock it for 6. So let me go through these cases. Pericardial cyst or spring water cyst. Could it be a pericardial fat pad? It could be, but it's a bit too asymmetrical. So I would always favour a pericardial cyst. Could it be a Morgani hernia? Not really, because there's no bowel gas. Okay.
Okay.
Acromegaly, spade-like terminal tufts, massive hands. You sometimes see TFC calcification. Not in this case, you don't. Widened joint spaces. The patient is asked to clench their teeth, and this patient is not clenching the teeth. And so this is a dislocation. It's either unilateral or bilateral, but this is dislocation of the teeth, of the TMJs, to open the jaw. Yeah, you smashed this one. That was LCH. It's random rather than centrolobular, but everything else she said was absolutely spot on. So that's fine. This is really, really difficult. And that was a left lower lobe collapse that I saw on a barium meal. Okay, so the GI tract was normal, but we saw that left lower lobe collapse, did a chest x-ray, then did a CT. It was a left lower lobe collapse from a carcinoma. Abdominal film, there's a lung mass on the film. And this is, it looks like it's an extension of the lead, but actually the lead goes there, and then this is calcification. That's a pericardial fat pad. Left ventricular aneurysm. Rib notching, but if you look on the side of the film, you can see extra pleural lesions, and this is neurofibromas. Osteoporosis circumscripta, knock it for 6.
Thank you.
PTLD, did really well on that one. So that's PTLD, ascites, retroperitoneal and mesenteric lymphadenopathy, thickened bowel loops, and transplant kidney. And then scleroderma hands, and you went through the lung and the esophageal dilatation findings, and then stress fracture. Yeah, you did really well on that. So all of you did extremely well. I think you are going to pass the exam if you adopt that sort of approach. Everyone can do better. There's no one who puts in a performance who says, that's as good as I could have done. I could have done better. So that is always going to be true, but I think you did really well. You all did enough to pass. And all I want to do now is just show you the course that I'm going to run, and it's at the end of it's going to be at the end of December and the beginning of January. We're going to do radiology masters course where we do sit down hot seat vivas in front of an audience, show you loads and loads of films just like this, but many, many more. And I hope you will sign up for it. And thank you very much for your attention. I hope you enjoyed
Yes, thank you so much, sir.
teaching. And please do put some feedback. Let me know how I did. And thank you to Sami Khan and his team for kindly letting me show you some cases. And I hope you all do very well in the exam. Cheers.